Namaste students, today we will be discussing one common and a very important case for both undergraduate and postgraduate students. Okay, this case will be kept as a short case in some of the universities where there is no need to take the history. But because there is no short case in DNB examination, are relevant and some important points in the history I will be taking in this case. For example, in our university, Rajiv Gandhi University in Karnataka, this will be kept as a short case where there is no need to take the history. Okay. But because for the DNB students beneficial, I will be presenting this as a semi-long case with a short history. Okay, so a case what I will be discussing today is nothing but Heptosplenomegaly case. Okay, so let us go ahead with the case discussion. A patient by name X is aged about 34 years. He is from Kolar district. History is given by the patient and it is reliable. Chief complaint: history of early satiety since 6 months, history of abdominal discomfort since 6 months, history of pain and heavy sensation in the left hypochondric region since 6 months. Let us go ahead with the history of presenting complaint. Patient was apparently normal 6 months back when he started experiencing early satiety after taking the food. There is no history of vomiting, nausea or weight loss. Why this history is important is history of vomiting, nausea or weight loss is even early satiety can be a feature of gastric outlet obstruction. In gastric outlet obstruction, patient will also have a history of vomiting, nausea and also patient will develop the weight loss. That's why that history of vomiting, nausea and weight loss is important in this case to ask. Patient says there is history of pain and heavy sensation in the left hypochondric region. And he says there is abdominal discomfort since 6 months and whatever the pain he is having, it is constant. It is not related to the exertion or there is no radiation. Just to rule out a cardiac pain where even they also will have pain in the epigastric region. That is why I asked whether the pain is related to exertion or not. So this pain, he says it is constant and it is not related to exertion and there is no radiation. And the pain, the quality whatever he says is dull aching. And discomfort will increase on taking the food intake. Whatever the discomfort he is having is increasing with the taking the food intake. So in a case like this, what are the negative points you ask? Okay, in a case of hepatosplenomegaly, what are the negative points you will ask in the history to rule out the differential diagnosis? Okay, there is no history of fatigue, tiredness, palpitation. This history, why you have to ask history of fatigue, tiredness and palpitation is because the anemias, especially the hemolytic anemias and even megaloblastic anemia can have a splenomegaly. Okay, that is why you have to ask this history of fatigue, tiredness, palpitation. No history of fever or yellowish discoloration of the urine or the eyes. This history is important. No history of fever to rule out the infectious causes, the bacterial causes, the viral infectious causes, for example, cytomegalovirus, Epstein-Barr virus, which can produce a splenomegaly. Then jaundice, the history of yellowish discoloration of the urine and the eyes. That history is important because infectious hepatitis, tender hepatomegaly and splenomegaly. That is why history of yellowish discoloration of the urine and eyes is important. There is no history of cardiac symptoms such as chest pain, palpitation, swelling of the legs, breathlessness, syncope. Why cardiac symptom is important in hepatomegaly and splenomegaly is because in a congestive heart failure, they can have a hepatomegaly and the congestion can also produce a splenomegaly. Not only that, if there is any underlying cardiac lesions, if they have fever along with that, then we have to suspect subacute bacterial endocarditis which can have splenomegaly. So that is why you have to ask history of cardiac symptoms like chest pain, palpitation, swelling of legs, breathlessness and syncope. No history of evening rise of temperature or weight loss. This history is very important in India because tuberculosis is so rampant. A disseminated tuberculosis will present with the history of evening rise of temperature and weight loss. They did not have like a pulmonary tuberculosis, cough and sputum production. They'll just have fear of unknown origin, weight loss, okay, and they can come with hepatosplenomegaly. That is why you have to ask history of evening rise of temperature and weight loss. And there is no history of intermittent fever. Again, this history is very important in a tropical country like India, where malaria is very common. So whether patient is getting intermittent fever, you have to ask in the history. No history of any multiple joint pains. This history is important because a polyarthritis is a feature of rheumatoid arthritis and SLE, where a patient can have a hepatosplenomegaly. That is why your ask history of any joint pain is there. No symptoms suggestive of thyrotoxicosis. The thyrotoxicosis symptoms like palpitation, sweating, and tremors. And why this history is important thyrotoxicosis symptom is they can have splenomegaly, benign lymphoid hyperplasia. Okay, a thyrotoxicosis patient can have a benign lymph node hyperplasia along with splenomegaly. It's a disorder of immune regulation. Okay, by which they can have splenomegaly. That is why thyrotoxicosis symptoms is important in the case of hepatosplenomegaly. No history of anorexia or weight loss. And this systemic symptom like anorexia and weight loss is important not only from tuberculosis point of view, but also a malignancy. Any malignancy like say a lung, say a stomach, or lymphoma, leukemias can go and infiltrate the bone marrow, producing a myelofibrosis with myeloid metaplasia. The bone marrow function will be taken over by the liver and spleen, where spleen can be enlarged in size. So, to rule out myelofibrosis, you have to ask this history of any anorexia or weight loss, and also a triad of lymphoma symptoms, that is drenching sweats, weight loss, and fever. That history is important in any case of hepatosplenomegaly. History of drenching sweats, fever, and weight loss, because a lymphoma can have a splenomegaly and even hepatomegaly. Then next symptoms, you have to ask symptoms of any cirrhosis like abdominal distension and again jaundice. Why cirrhosis symptoms is important? Cirrhosis can produce splenomegaly by congestion. Okay, one of the congestive cause of the splenomegaly is cirrhosis. So, symptoms suggestive of cirrhosis you have to ask. Again, symptoms of portal hypertension. Again, a portal hypertension will produce a congestive splenomegaly. You have to ask that history. So, that is the swelling of abdomen or any hematemesis or melena, which can suggest portal hypertension. So, the history of hematemesis and melena you have to ask. Then you have to ask symptoms suggestive of bleeding manifestations like petechiae, purpura is there. Okay, though that is a sign, some patient may approach a doctor with their having petechiae and purpura. Why this history petechiae and purpura in hepatosplenomegaly is important is because idiopathic thrombocytopenic purpura (ITP) will have splenomegaly, and also leukemias can have low platelets and splenomegaly. That's why the history of bleeding manifestation like petechiae and purpura is important. So these are the relevant points which we will ask in the history coming to the differential diagnosis whenever you have a hepatomegaly or splenomegaly. Coming to the past history, there is no history of diabetes, hypertension or tuberculosis. Occupational history is important because some of the toxins, radiation exposure and strontium can invade the bone marrow, producing myelofibrosis and extramedullary hematopoiesis. So, myelofibrosis with myeloid metaplasia. So, that is why occupational history of toxins, radiation and strontium is important. Then history of drug history is very important because the drug reaction can produce because of the immune dysregulation of splenomegaly in drug reactions. And also IL-2 therapy, interleukin-2 therapy can produce a splenomegaly because of immune dysregulation. So history of drug reaction and IL-2 therapy is important. Coming to the personal history, there is no history of alcohol. Just to rule out the cirrhosis, you have to ask that history which can produce splenomegaly. Diet is important because a pure vegetarians will develop B12 deficiency, megaloblastic anemia, which can have a splenomegaly. So he takes a mixed diet, and no other addictive habits. Addictive habits again for alcohol you have to ask and smoking. And there is no high risk behavior. Why high risk behavior is important is because HIV patients can have a hepatosplenomegaly. That is why that is important. No high risk behavior. Family history, there is no significant family history. Family history in this case may be relevant to rule out the hemolytic anemias, because hemolytic anemia can have a splenomegaly. So these are some of the relevant points which you will ask in the history. Our patient doesn't have any of this history. Only he has a symptom of early satiety, abdominal discomfort, abdominal pain, that too which increases with food intake. Okay, right. So this is the history. So any of the etiology, whatever I told, the DD is relevant to the points he is not having. But he belongs to a tropical endemic area like India. Let us see probably what he is having after the examination, after the investigation. So what he is suffering from. So let us see why he is having hepatosplenomegaly. So students, let us come to the general physical examination. Patient is conscious, cooperative, well oriented to time and place. The vitals, pulse is 82 beats per minute and regular, good volume, all the peripheral pulses fine. Blood pressure 120 by 80, patient is afebrile, respiratory rate is 16 cycles beats per minute. Come to the examination. So let us go from top to bottom examination. Okay. So first pallor, can male notice? There is no pallor. Can Kalya nodi? There is no icterus. And pallor, why important in this case is patient with hemolytic anemias can have pallor. Patient with leukemia and lymphoma can have pallor. And patient with connective tissue disease like rheumatoid arthritis, tuberculosis can have pallor. So relevant to those diseases, examination of pallor is important. Then jaundice is important in this case because of cirrhosis which can produce a jaundice. Next is lymphadenopathy. You have to go behind the patient, examine for the lymph nodes. There is no lymphadenopathy. What are the cause of hepatosplenomegaly with lymphadenopathy? In India, first and foremost, you have to consider tuberculosis. HIV can have hepatosplenomegaly with lymphadenopathy. Leukemias, especially lymphatic leukemias. Lymphomas can have hepatosplenomegaly with lymphadenopathy. Cytomegalovirus, Epstein-Barr virus can have lymphadenopathy with hepatosplenomegaly. Sarcoidosis, histoplasmosis can have hepatosplenomegaly with lymphadenopathy. So these are the diseases which we will consider in examining lymphadenopathy. Next is clubbing. There is no clubbing. There is no clubbing. Clubbing may be relevant in this case because subacute bacterial endocarditis which can have splenomegaly will have clubbing. So in that point, clubbing is relevant. So pallor, as I told, anemia, leukemia, lymphoma, tuberculosis, connective tissue diseases. Then clubbing because of subacute bacterial endocarditis. Lymphadenopathy, lymphoma, leukemia, HIV, tuberculosis, infectious mononucleosis, and cytomegalovirus. Let me look for the cyanosis. Yeah, no cyanosis. It's not having cyanosis. Next is edema. I will make him lie down. I'll check for the edema. So you have to look for edema. Let me look for edema. Just above the medial malleolus, you have to press for 30 seconds. There is no edema, okay, in these patients. Okay, edema is important because of cirrhosis, portal hypertension, and also congestive heart failure, which can produce splenomegaly. Portal hypertension, cirrhosis, and congestive heart failure, which can produce splenomegaly. So what are the other things you look in this case, okay, for in a case of hepatosplenomegaly? You have to look for any petechy and ecchymosis. As I told in the history, why you have to look for petechy and ecchymosis? Because ITP, leukemias will have thrombocytopenia which can have petechy and ecchymosis. For that you have to look. And from top to bottom, you have to look for liver cell failure features, which I discussed in the cirrhosis of patients: alopecia, jaundice, gynecomastia, pyruvate enlargement, dupigenous contracture, leukonychia, flapping tremors, testicular atrophy, spider nevi, caput medusae. So these liver cell failure you have to look, because a cirrhosis with a portal hypertension can have a splenomegaly. That is why you have to look for top to bottom whether there is any liver cell failure feature is there. You have to look, and also you have to look for markers of tuberculosis, because tuberculosis can produce a splenomegaly. So you have to look for frequent conjunctivitis, erythema nodosum, scrofulacia, lupus vulgaris, epididymoarthritis, and fungal infections. So markers of tuberculosis. Then in knuckle pigmentation, you have to look for knuckle pigmentation. Okay, our patient is not having knuckle pigmentation. Okay, knuckle pigmentation indicates B12 deficiency, which can have a splenomegaly. That's why you have to look for knuckle pigmentation. Then the two important things in this case probably relevant is sternal tenderness. Okay, sternal tenderness, you have to look for sternal tenderness. It is not there. And then you have to look for rise JVP. The rise JVP is feature of congestive heart failure, and congestive heart failure can produce a congestive hepatosplenomegaly. Okay, and even hepatomegaly, congestive hepatomegaly. That's why a rise JVP, sternal tenderness, is important in these cases of hepatosplenomegaly. Then one more important thing probably in a childhood pediatric age group will be retinal examination in a case of hepatosplenomegaly, because to rule out storage diseases. So there will be a retinal manifestation of those storage diseases like Gaucher's disease, Niemann-Pick disease, Fabre's disease, Tangiers disease. So retinal examination is important for storage diseases. So you have to look for that. So this is the top to bottom general field examination which you will look, okay, in a case of hepatosplenomegaly like this case. Okay, now let us go to the examination of the abdomen. So let us go ahead with the examination of the inspection of the abdomen. Okay, so first is inspection of the shape of the abdomen. The shape of the abdomen here is normal only. The normal shape of the abdomen is scaphoid shape. Okay, and it will be distended and globular if there is a fluid accumulation. Okay, fat or air, flatus, fetal growth, or a fetus. It will be a distended. So here it is appears normal in shape. Okay, then whether it is moving with respiration, you have to see. You can closely observe the abdominal wall is moving up and down. Okay, it is moving with respiration. If there is peritonitis, the abdomen doesn't move with the respiration. So you have to see that. Then any distended veins are there, you have to see in the abdomen. Distended veins indicates a caput medusae, a cirrhosis of liver whenever there is a portal hypertension. Portal hypertension. Any visible gastric peristalsis from the left hypochondric region and epigastric region to the right lumbar region, if it is there, you have to see visible gastric peristalsis. It is not there, visible gastric peristalsis. Then any Cullen sign or Great Turner sign, okay, the bluish discoloration surrounding the umbilicus and the flanks, okay, it is not there, okay, which indicates necrotizing pancreatitis. Then any visible abdominal aorta pulsation is there, you have to see. It is not visible, any visible abdominal aortic pulsations. So the inspection, shape, then the umbilicus. Umbilicus is transversely stretched and it is not everted. Okay, you get the umbilicus everted in ascites, where whenever there is a fluid accumulation, the umbilicus will be everted. So movements, it is moving with the respiration, no visible gastric peristalsis, and there are also no striae. Here there is striae albicans. So you can make out the striae albicans here. The purple striae is a feature of Cushing syndrome. Okay, right. So no scars and sinuses, and there are no visible veins. Okay, now let us come to the palpation. Palpation, you have to take a spinoumbilical measurement and epigastric umbilical measurement. I have taken the measurement The measurement is spinoumbilical measurement is 22. The xiphisternum to umbilicus is 21. From umbilicus to pubic symphysis is 13. Okay, now let us go to the examination of the palpation of the organs. Okay. First, I will do a superficial palpation, then I will show how to palpate for all the organs. Okay, right. So, first you have to start the palpation from the left iliac region. In the anti-clockwise rotation, you will start palpating. Okay. If you find any abnormality, then you have to start palpating for the organs. Okay. In superficial palpation, I am feeling the abnormality. There is a organomegaly. Okay. I can feel the spleen and liver. Now I will show how to palpate for the spleen, liver, kidney, spleen, liver and kidney. Okay, let us go to the examination. First, the liver examination. So students, I will tell the methods to palpate the liver examination. Okay, Achison has given around 4 methods to palpate. Okay, even the clinical method books also gives around 4 methods. Okay, all the 4 methods I will show how to palpate. Okay, first let us palpate with a classic method. The patient should fold the legs like this. Ask the patient to breathe through the mouth. The breathe through the mouth. Okay, the head should be turned towards the left side. Okay, the first method I will show. You have to palpate from the right iliac fossa parallel to the costal margin. Then with each expiration, you have to move your hand upwards. In inspiration, it will come and touch your finger. It is enlarged. Okay, right. Arama study first. Yeah, I am feeling the border here. Okay, this is the costal margin around 2 centimeters from the costal margin. The liver I am able to feel, and when you able to feel the liver, you have to see how the border is, how the consistency is, whether tender or non-tender. Okay, and surface. I'll explain in different condition how it look, but here I am palpating here. The other method to palpate is Achison gives the 2 hands from the right iliac fossa. You move upwards. Okay, I'll show that method. So with the 2 hands like this, with each expiration you move your hand. With inspiration, it will come and touch. Now I can feel here. This is the border. Okay, the liver. Okay, that. This is the second method. The third method is dipping method in ascites patient. Suppose this fluid is there, then you have to dip the fluid. Okay, like this you have to do. The left hand will displace the fluid like this, and the right hand will palpate the organ. Okay, dipping method. So a dipping method, a sudden jerk you have to give. Okay, and you have to palpate it. That is a dipping method. And how to look for the pulsatile liver. I'll demonstrate how to look for the pulsatile liver. You have to palpate the liver with the right hand. The left hand should be put laterally to look for the pulsations. Okay, pulsatile liver. I will show how to look for it. You palpate the liver, the right hand, and then you put like this, the left hand laterally. So you look for the pulsatile liver. One more method for pulsatile liver is you can put the hand like this. Golwala gives this. You can look for a pulsatile liver. So whenever you get a liver, the things what you look is, okay, the border. The border will be rounded in congestive heart failure and infectious hepatitis. The border will be sharp in cirrhosis. Then the consistency, a firm liver you get in cirrhosis, a soft liver you get in infectious hepatitis and heart failure, a stony hard liver you get in hepatoma. Then surface a nodularity you get in secondaries of the liver surface. Then you will have to see whether tender or non-tender. A tender hepatomegaly is a feature of infectious hepatitis like A, E, or even acute hepatitis B also. So, because of stretching of the capsule, because the liver will enlarge in size. Heart failure, that can be a tender hepatomegaly. liver abscess, either pyogenic or amoebic, there will be a tender hepatomegaly. Very rarely, hepatoma. Secondary is actinomycosis, Buchiari syndrome. You will get a tender hepatomegaly. Then pulsatile. A systolic pulsation is a feature of tricuspid regurgitation. A diastolic pulsation is a feature of tricuspid stenosis. And aortic regurgitation, you may get a pulsatile liver. These are the things which you see in liver palpation. The liver percussion I will tell later, and liver span, how to look for that when I percuss the liver. Now let us go to the examination of a spleen, which is very important, spleen examination. Spleen, again, there are 4 methods which I will teach all the methods. Okay. The first method is the classic method, which will go from a right iliac fossa towards the left costal margin. That's the first method. If you don't get by that method, then make him right lateral. Put your left hand behind his rib cage. That is the second method. Third method is hooking method. The fourth method is Middleton maneuver, which I will show how to look for that. And the fifth method is dipping method. First method, classic method. You go from a right iliac fossa. With each inspiration, it will come and touch. If expiration, you have to move it. See, you're almost, I am getting the spleen here in this case, here in umbilicus only. Okay, in umbilicus, the spleen is there. Okay, suppose if you don't get the spleen by this method, then you have to make him right lateral. These are 3 equals right side. Make him right lateral. Then put a hand behind the rib cage. Then start palpating from the right iliac. Okay, you have to palpate to the costal margin. Here only, just around the umbilicus, it is there, the spleen. This is the second method. The third method is sternum bulbar. Okay, right. Dipping method, as you do for as you did for the liver. Okay, you dip it. Displace the fluid with the left hand, palpate with the right hand, dipping method. This is the third method, especially you do that only in ascites. Now let us go to the hooking method. So the next method is hooking method. Hooking method is done from the left side of the patient, okay, with your left hand. You have to insinuate your finger under the rib cage. Then next is Middleton maneuver. Middleton maneuver is with the hook your hand, okay, and you put a pressure behind the rib cage. That is a Middleton maneuver. Middleton maneuver. Okay, these are the methods which you palpate for the spleen. Spleen here in this case is enlarged 8 cm. How do you grade a splenomegaly? 5 cm is mild, 5 to 8 is moderate, more than 8 is massive splenomegaly. Okay, so a spleen like this, massive splenomegaly, if it is enlarged more than 8 cm, what are the diseases you will consider? In India, first and foremost is tropical splenomegaly. That is the first condition which you will consider. Then here is a leukemia, can produce a massive splenomegaly. Lymphoma, non-Hodgkin's lymphomas. A myeloproliferative disorder, the chronic myeloid leukemia, CML, will have a massive splenomegaly. Then myelofibrosis with myeloid metaplasia. Autoimmune hemolytic anemia, Gaucher's disease, chronic lymphatic leukemia, diffuse splenic angiomyomatosis. Okay, these are the conditions where there will be a massive splenomegaly and sarcoidosis. Okay, right. Now, how do you palpate? Then, how do you distinguish splenic swelling from a kidney swelling? This is a basic question. All the examiners will be asking, and you have to know this. How do you distinguish splenic swelling from a kidney swelling? Splenic swelling will have a notch. Kidney doesn't have a notch. Spleen will enlarge towards the right iliac fossa. Kidney will enlarge top to down. Kidney is a retroperitoneal. It doesn't move with respiration. Spleen will move with respiration. In a splenic swelling, there will be an anterior band of resonance. Kidney swelling, you won't get an anterior band of resonance. Renal angle is dull to percuss in a kidney swelling, but not in a splenic swelling. So, where is the renal angle? I will just show the renal angle. The renal angle, the erector, the spine, okay, and then the 12-3, that angle is the renal angle. You have to percuss there. If kidney is enlarged, that angle will be dull to percuss. Okay. So, next students, I will tell how to palpate for a kidney swelling. Kidney swelling, student, is bimanually palpable. And another thing is palatability. These two things you should know, bimanually palpable and palatability. And one more point is left kidney is palpated from the left side. Okay. Now, bimanual palpation, kidney swelling. You have to put your hand like this, press together like this. This is a bimanual palpation. Okay. Put your hand like this, press together like this. That is bimanual palpation. What is palatability? You give a jerk like this, it will come and hit here, and you give a sudden jerk, the kidney will come and hit the lower hand. Okay, but palatability is like this. This is palatability. Okay, so that is a kidney swelling. Next, other two things is gallbladder palpation and Murphy's sign. Gallbladder palpation, you will palpate just lateral to the junction between the costal margin and the rectus abdominis. Okay, let me palpate for the gallbladder. So this is the rectus abdominis, and you have to palpate here for the gallbladder. Okay, usutoguli saku. Suppose with the deep inspiration, if there is a pain, that is known as a Murphy's sign, which is seen in acute cholecystitis. And in gallbladder enlargement, you should know about Kurzweil's law. The Kurzweil's law is, if at all a gallbladder is enlarged, it is due to CA pancreas, but not due to the gallstones. Why? Because in a cholelithiasis long standing, the gallbladder wall becomes fibrous and the size will become very small. So, if at all a gallbladder is enlarged, it is due to the CA pancreas, but not due to the gallstone. That is Kurzweil's law. So, this is gallbladder palpation. So, you should know this much about the palpation of the abdomen, students. So, our patient is having hepatomegaly 2 centimeters, a splenomegaly 8 centimeters below the umbilicus. Now, let us go to the percussion. Percussion, first I will do a liver percussion, liver span, then shifting dullness and fluid thrill. So, liver dullness I will percuss the liver dullness. This is the angle of Louis. Second space resonant. Third space. Fourth space. This is fifth only dull. The normal liver dullness is fifth space, fifth only dull. Let me percuss down. Dull, dull, and here it is tympanic. Okay, so this much is the liver span. You have to measure from here to your mid-clavicular line. I measured it. It is coming around 14 centimeters. It is coming around 14 centimeters, the liver span. Okay, that's how you measure the liver span. Okay, right. Now, shifting dullness and fluid thrill you have to do. Let me check that. So, students, I demonstrate a shifting dullness. Okay, may not be relevant in this case, but in ascites it is relevant, which I already demonstrated in all the cases. But again, I will demonstrate. Okay, so if at all, whether I will get tympanic, everywhere tympanic is there, students. Okay, there is no dullness, so there is no fluid. So question doesn't arise to check for a fluid thrill. Just I'll demonstrate the method to check for the fluid thrill. Sanju ಈ ಕೈ ಇದೆಯಲ್ಲ ಹೀಗೆ ಇಟ್ಕೋಬೇಕು, ಹಿಂಗೆ ಅಲ್ಲಲ್ಲ ಹಿಂಗೆ ಇಟ್ಕೋಬೇಕು. Okay, good, nice. Yeah. So I'll demonstrate fluid thrill. Okay, so not relevant in this case, but just for a completion purpose. Okay, right. So these are the things which you look in the percussion. So let me go for auscultation. Okay, right. Okay, students, let me auscultate. Before auscultating, I'll tell what all we have to look. First is the bowel sounds in ileocecal region. Okay, that is 2/3 of the splenomegaly line and 1/3. Okay, normal bowel sound is 3 to 5 per minute. For 1 full minute, you have to auscultate. Okay, and then you have to look for any bruit over the liver, which you get in hepatoma and acute hepatitis. Okay, and then any rub over the liver because of the perihepatitis, or any rub over the spleen because of perisplenitis, which you will get in subacute bacterial endocarditis, sickle cell anemia, splenic infarction, and after a splenic biopsy. Then very venous hum in between xiphosternum and umbilicus, which is known as curvular Baumgarten syndrome because of the opening up of the umbilical vein and portal vein. Right. Percussion students, we should percuss the spleen. There are three methods for percussion of spleen. Okay, the three methods are: one commonly used is drops percussion, drops area percussion, Castle method, and Nixon method. First I will do the percussion of drops area and Castle method, then I will show the Nixon method. The drops area percussion, there are two ways to define the boundaries. Okay, sixth rib above is the second rib, third rib, fourth rib, fifth rib, sixth rib. Okay, the sixth rib above, costal margin below, mid axillary line laterally. This is a space. Okay, drop space, sixth rib above, costal margin below, mid axillary line laterally. The other way to define boundaries are right side by the left lobe of liver, left side by the spleen, above by the lung resonance, below by the costal margin. Normally, this is resonant to percus drops area. If it becomes dull, that indicates splenomegaly. Drops area can also be dull in a carcinoma of the fundus of the stomach, pleural effusion, pericardial effusion, splenomegaly. It will become dull to percus. Let me percuss the drops area. First, I will percuss here. You see resonant. You have to start percussing from medial to lateral usually. So, it is dull to percuss. This is drops area percussion. This is one method. The second method is Castle method. Castle method, in the anterior axillary line, in the 8 or 9 space, patient should take a deep inspiration. That should be resonant. If 8 or 9 space is dull to percuss and taking deep inspiration, that indicates splenomegaly. Let me come to the 8 spaces: second, third, fourth, fifth, sixth, seventh, 8th space in anterior axillary line. I have to percuss here. Okay, patient should take deep inspiration. So it is dull to percuss. See a resonant in anterior axillary line. Just little down. This is dull to percuss. This is the Castle method in supine position. You have to do that. The next is Nixon method. Okay, I will show the Nixon method. So Nixon method, student, first I will explain. Patient should be made in right lateral position like this. Then in the posterior axillary line, from the lower part of the lung resonance, you will start percussing towards the left costal margin. Then wherever you get the dullness, from that dullness point to the midpoint of the left costal margin, that distance should be 6 to 8 centimeters. If it is more than 8 centimeters, that distance, then that indicates splenomegaly. Okay, right. So you have to come from a lung resonance lower part in a posterior axillary line. Okay, then you have to come percussing towards the costal margin. So here you are getting the dullness. This distance you have to measure. Okay, from the costal margin. Okay, I measured it. It is coming around 8.5 centimeters. Normally 6 to 8 centimeters. Okay, this distance. If this distance is more than 8 centimeters, that indicates splenomegaly because spleen expands posteriorly. So in a posterior axillary line, from a lower part of lung resonance, you start percussing towards the costal margin. Wherever you get the dullness, you take a measurement from the costal midpoint of costal margin to that point. This distance is normally 6 to 8 centimeters. If this is more than 8 centimeters, that indicates splenomegaly because spleen goes backwards. Okay, these are the three methods to percuss the spleen. Okay, let me look for those things. First, vowel sounds. It is present 3 to 5. Let me look for any bruit. Venous hum. Rub over the spleen. So these are the things which you will look, okay, students, okay, in auscultation. Okay, now coming to the other systems, the CVS, RS, CNS is normal in him. There is no abnormality. Okay. So students, history-wise, he has only a nagging, dull aching pain and early satiety. No other symptoms suggestive of the cause for his hepatomegaly or splenomegaly. So the investigation, what you do in such sort of cases to find the cause of hepatomegaly or splenomegaly is you have to do a CBC. A CBC is relevant in this sort of cases because the hemoglobin may be normal. Hemoglobin may be reduced, for example, in hemolytic anemias or a congestive splenomegaly or a connective tissue disease like SLE, tuberculosis or rheumatoid arthritis can produce anemia. So RBC may be reduced. RBC may be increased in polycythemia vera, which can produce a splenomegaly. That is why RBC count is important. Now let us go to the neutrophil count. Neutrophil count may be normal, reduced or increased. Neutrophil counts will be reduced in a Felty syndrome with rheumatoid arthritis where there can be a splenomegaly, or in a leukemia it can be reduced, or a congestive splenomegaly because of portal hypertension. Neutrophils may be increased in infection, inflammation and leukemias. Neutrophils may be increased. That is why neutrophil count is important. Next is platelet. Platelet may be normal, reduced or increased. Platelet will be reduced in idiopathic thrombocytopenia purpura with splenomegaly, or platelet may be increased in a myeloproliferative disorder like polycythemia vera. So that is CBC, a basic investigation, but which will give a lot of information. In this patient, CBC is normal. The next is peripheral smear. Peripheral smear is important because it will give a clue if there is an anemia is there, any type of anemia. That is a peripheral smear is important. And also leukemias, blast cells, if it is there, it will pick up. Then the endemic country like India, malarial parasite it can pick up. In our patient, peripheral smear is also normal. He is not having any abnormality in the peripheral smear. Then LFT, our patient is not an alcoholic, but LFT you have to do for two things. One is it may give a clue to the hepatitis, which can produce a tender hepatomegaly and splenomegaly, where a very huge elevation of liver enzymes will be there. Or a cirrhosis patient, it may give a picture of alcoholic cirrhosis where SGOT will be more than SGPT. So LFT is relevant in that respect, in that prospect. Next is, if you would have give history of joint pain, then full connective tissue disease profile you have to work it out. But here is not giving joint pain history at all, so no need to do a connective tissue disease workup. Then suppose if you would have had a history of fever, a short history of fever with splenomegaly, then you will think of infections like a typhoid fever, a malarial fever, or infectious mononucleosis, cytomegalovirus. So you have to do the investigation relevant to the infective etiology which you are thinking. For example, cytomegalovirus, infectious mononucleosis, HIV and a blood culture. But he never gave history of fever, so no question arises to rule out any infectious cause. Then suppose if the CBC was showing abnormality or peripheral smear was showing abnormality, bone marrow is important. Bone marrow is important to rule out the leukemia, lymphoma and myelofibrosis, where there will be a dry tap. So lymphoma, leukemia and myelofibrosis, bone marrow should be done. We are not done in him because the peripheral smear and CBC is normal. Then imaging, a simple chest X-ray to rule out tuberculosis, which can have a hepatosplenomegaly or disseminated tuberculosis. Ultrasound scan abdomen to rule out cirrhosis. Okay, here there is no features of cirrhosis at all, so we didn't do any ultrasound scan abdomen. So all the relevant investigation, the blood investigation is normal in him, okay, and there is no symptom, but he has a mild hepatomegaly and a massive splenomegaly. So leukemia, everything ruled out, anemia, hematological problems, the cirrhosis, the condition diseases are ruled out. So probably in this case, what we can consider in an endemic country like India, probably he may be suffering from a tropical splenomegaly syndrome. a tropical splenomegaly syndrome. Probably that is a diagnosis what we can consider being a tropical splenomegaly syndrome. Okay. So here I just want to tell a brief points about tropical splenomegaly, and then I want to discuss detail about splenomegaly also. Tropical splenomegaly, also known as hyperreactive malarial syndrome. Tropical splenomegaly will be asked as a short note even in your theory questions, students. And even if a massive splenomegaly like this, if it is present, it will be kept also for examination, for your examination. Tropical splenomegaly is also known as hyperreactive malarial syndrome. This is because of the repeated malarial infection. There will be a B cell hyperactivity synthesizing a IgM antibody against the malarial antigen. There will be twice the elevation of the IgM level in the blood. One interesting thing in tropical splenomegaly is you won't find the malarial parasite in the peripheral blood smear. But there will be IgM against the malarial antigen, twice the elevation. What are the diagnostic criteria for tropical splenomegaly syndrome? They should have a massive splenomegaly like this, associated with hepatomegaly, then IgM elevation more than twice the normal. And patient should respond clinically, and biochemistry also should come to normal with the long-term therapy with the treatment, anti-malarial treatment. This is the diagnostic criteria. Hepatomegaly, splenomegaly, IgM elevation more than twice the normal, and the patient clinical symptom and the investigations, biochemical investigation should come to normal with the long-term antimicrobial therapy. So what is the treatment for tropical splenomegaly syndrome? You can give proguanil 200 mg, chloroquine, pyrimethamine, a lifelong therapy. That is a treatment for tropical splenomegaly. Then what is the prognosis for tropical splenomegaly syndrome? The prognosis for tropical splenomegaly syndrome is good, is very good, but they may develop a splenic B cell lymphoma, and you should never do splenectomy or irradiation or anti-mitogenic treatment for splenomegaly. Splenectomy is never done, splenic irradiation you should not do, and anti-mitotic therapy should not be given. So promptly response, but there is increased morbidity because of the secondary infection, and B cell lymphoma can develop, and if they have anemia, it can produce cardiac failure. So tropical splenomegaly, it is a good prognosis, but they may have morbidity because of the infections. They may develop cardiac failure because of anemia, or splenic B cell lymphoma can be developed. There is a prognosis, okay, and complications. Okay, students. So let me tell a few points about splenomegaly and splenectomy, which is given in Harrison textbook, because questions will be asked on that whenever you get a case like this about splenomegaly. Okay, so a brief introduction about the embryology. The spleen develops from the mesogastrium in the 5th week of gestation from a series of hillocks. It is attached to the stomach by gastrorenal ligament, and it is attached to the kidney by linorenal ligament. In 20% of the cases, there will be accessory spleen. Then coming to the physiology, the spleen has a red pulp and a white pulp. The white pulp contains the B lymphocytes, then marginal lymphocytic area and T lymphocytic area, which will be surrounding the central arteriole. The white pulp secretes the immunoglobulins and autoantibodies. The red pulp has the cords and sinuses. The blood, whatever which is enter the sinuses, will go back to the circulation through the splenic venules. But the cords are dead ends. The blood which enters the cords will undergo an inspection by the slits. Those organs which are good deformable, they are good, they only can pass through the slits. Those which are old age and the damaged RBCs will get destroyed there in the cords. Then what are the 3 important functions of spleen? Spleen will act as a quality control for erythrocytes, Which are the damaged erythrocytes spleen will destroy? That is the first function. Then it synthesizes the antibodies. That is the second function. And in extraneous conditions, whenever a bone marrow is damaged, spleen can recapitulate the function of synthesizing the formed elements. That is metaplasia, myelofibrosis with myeloid metaplasia will occur. These are the three functions of spleen. Not only that, spleen also will remove the antibody coated the microorganisms and antibody coated RBCs from the circulation. These are the functions of spleen. Spleen is in a portal circulation. The reason for this not known, but probably because the blood flows very slowly in the portal circulation, the RBCs won't undergo much damage. That may be the reason why spleen is in the portal circulation. And the blood flow through the spleen is around 150 ml per hour. 150 ml per hour is the blood flow through the spleen. So then you have, for example, in the RBCs, suppose if there is a malarial parasite, or with the nuclear inclusions known as the Howell gel bodies, or the hemoglobin denatured substance like Heinz bodies. So if these structures are there in the RBCs, the spleen will cut all these things, Howell gel body, Heinz body. That is known as a pitting. This function is known as a pitting. Whereas the removal of the old RBC is known as a culling. The culling and pitting is a feature of spleen. The culling and pitting occurs at a normal pace only because the blood flow is not very much slow in spleen compared to the other systemic organs. So culling and pitting occurs at a normal flow only. This is a brief introduction about the spleen, the anatomy and physiology, and it has three adaptive functions. The three adaptive function is it synthesizes the antibodies and extramedullary erythropoiesis. Whenever there is a bone marrow damage, spleen will recapitulate the function of bone marrow and start synthesizing the formed elements, and it removes the microorganisms and antibody coated RBCs from the circulation. Coming to the clinical approach to the patients, and also one more thing is in animals that is called as auto transfusion. That means some amount of blood is pooled in the spleen. Whenever needed in an emergency, that blood will be pooled back to the circulation. In the animals known as auto transfusion. But in humans, that function is not that much studied. But definitely in humans, 1/3 of the platelets will be in the spleen, and a significant amount of neutrophils will be in the spleen. Whenever you need an infection or a bleeding, these platelets and neutrophils will be brought back to the circulation. Coming to the clinical approach, the splenomegaly, especially if a massive splenomegaly like this, if it is there, patient will have early satiety, left hypochondry, pain will be there, discomfort, a dragging side of pain will be there. The pain in splenomegaly is because of stretching of the capsules, infarction, or inflammation. Especially sickle cell anemia, because of the microinfarctions, patient will experience the pain. That is the commonest cause of splenic pain, which is described. Then spleen, because of the infiltration or because of the trauma, it can rupture. A splenic rupture can be painless. Splenic rupture can present with shock and hypotension. Then splenic, the dimension, cephalocaudal dimension is around 13 centimeter. The length is 12 centimeter. The breadth is 7 centimeter. The dimension of the spleen. Splenomegaly in an endemic area. For example, in New Guinea, which is near Australia, 60% of the population are having splenomegaly. Our patient is from Kolar. Kolar is an endemic area for malaria. That is why he is having a splenomegaly. It is a tropical splenomegaly because of repeated infection of the Plasmodium vivax. There is a hyperreactive malarial syndrome. Okay, that is in New Guinea. 60% of the patients may be having a splenomegaly. Splenomegaly always doesn't indicate a pathology. For example, in a Hodgkin's lymphoma, 1/3 of the patients, even if they have splenomegaly, it is not involved by the lymphoma. Similarly, spleen may not be enlarged in lymphoma in 1/3 of the patient, but it will be involved. So that caveat you should know in splenomegaly. Then coming to the other clinical aspect, the palpation and percussion, which I showed, the palpation different methods which I showed, and the percussion different methods. The palpation, the sensitivity is 56 to 71%. The percussion is 59 to 82% sensitivity. First, you have to percuss always. If it is enlarged, then you have to palpate it. If the patient is obese or taken the food, palpation and percussion is difficult to appreciate the splenomegaly. Then the different methods of percussion I showed. Then auscultation, you have to auscultate for a rub, which I told the conditions where you can get rub because of perihepatitis, subacute bacterial endocarditis, splenic biopsy, splenic infarction, you may get rub over a spleen. Then spleen area, other DDs which we will consider is a tumor from the stomach, tumor from the colon, pancreas. These are the DDs which we will consider, or kidney swelling also. Kidney swelling, pancreas, colon, stomach. These are the differential diagnosis which we will consider in a splenomegaly. Come to the investigation. The routinely, as you know, the cheapest, without any problem to the patient, transportable, the commonest investigation for a splenomegaly is ultrasound scan abdomen. You can do CT scan and MRI, which can tell exactly the size of spleen. MRI is not having any advantage over the CT scan. The nuclear scan you can do for a spleen, especially to detect the accessory spleens. The nuclear scan for the spleen. Again, as I told, you measure the spleen by ultrasound. The cephalocaudal diameter is around 13 centimeter. The length is 12 centimeter. The breadth is 7 centimeter. So those are the investigation which you will do in splenomegaly. If there is any splenic tumor, infarction or inhomogeneous infiltration, all three will detect: ultrasound, CT and MRI. But if there is a patchy infiltration like a lymphoma, very difficult to detect by these investigations. A patchy infiltration in lymphoma. Okay. So that is about the investigation. Now coming to the causes and differential diagnosis of splenomegaly. It is mainly divided under three headings, the causes of splenomegaly. The first heading is splenomegaly because of the increased function of the spleen. The normal function of the spleen is increased. Under this heading, there are four categories. The first category is increase in the reticuloendothelial action of the spleen. The increase in the reticuloendothelial action of the spleen you get in all hemolytic anemias. The spleen will destroy the abnormal RBCs. It could be hereditary spherocytosis, elliptocytosis, hemoglobinopathies like sickle cell anemia, thalassemia, enzyme deficiencies, paroxysmal nocturnal hemoglobinuria, and also even in megaloblastic anemia, spleen can destroy the RBCs. This is due to increased reticuloendothelial cell activity. That is the first category in increased splenic function. The second category is immune hypoplasia. Immune hypoplasia is the category where the spleen will enlarge as a reaction to the infections. The infection could be a viral infection like a viral hepatitis, HIV, it can be against HIV infection, infectious mononucleosis, cytomegalovirus, bacterial sepsis, splenic abscess, congenital syphilis, tuberculosis, subacute bacterial endocarditis, fungal infections, histoplasmosis, actinomyces, then parasites and protozoal, malaria, leishmaniasis, trypanosoma, ehrlichiosis. So these are the causes of immune hypoplasia. So septicemia, congenital syphilis, splenic abscess, subacute bacterial endocarditis, trypanosomiasis, ehrlichiosis. Okay, these are the causes of immune hypoplasia. Second category. The third category is immune dysregulation. Immune dysregulation. Here the causes are rheumatoid arthritis, Felty syndrome, SLE, connective tissue diseases and collagen vascular diseases, serum sickness, autoimmune hemolytic anemia, idiopathic thrombocytopenic purpura, thyrotoxicosis, as I discussed before. There can be a benign lymphatic enlargement, hyperplasia, thyrotoxicosis, interleukin 2 therapy, drug reaction, sarcoidosis. These are all the cause of immune dysregulation. So, under immune dysregulation, serum sickness, drug reaction, autoimmune hemolytic anemia, idiopathic thrombocytopenic purpura, sarcoidosis, thyrotoxicosis, interleukin 2 therapy, and angioimmunoblastic lymphadenopathy. Angioimmunoblastic lymphadenopathy. This is immune dysregulation. So, what are the three headings we discussed? One is reticuloendothelial hyperplasia, immune hyperplasia due to against an infection, immune dysregulation in all these conditions where autoantibodies will be produced by the spleen. The fourth is extramedullary erythropoiesis. Extramedullary erythropoiesis can occur because of marrow damage by a toxin, radiation, strontium, or because of the marrow infiltration by leukemia, lymphoma, Gaucher's disease. There can be marrow infiltration. So, extramedullary erythropoiesis, it can occur because of myelofibrosis, strontium, toxins, radiation, tumor, leukemia, Gaucher's disease. So, the first heading is splenic function is increased. Under that heading, these four subheadings: immune hyperplasia, immune dysregulation, reticuloendothelial hyperplasia, then myeloid metaplasia of the spleen. The second heading is splenomegaly because of the altered blood flow to the portal vein and splenic circulation, and spleen circulation. Under this heading, you get cirrhosis of liver, portal hypertension due to any cause and Bunty's disease, splenic vein obstruction, portal vein obstruction, hepatic vein obstruction, and cavernous transformation of the portal vein. Not only these things, splenic artery aneurysms, schistosomiasis. Okay, you getting schistosomiasis. So, enlargement due to abnormal splenic or portal blood flow, portal hypertension, Bunty's disease, splenic artery aneurysm, congestive heart failure, cirrhosis, cavernous hemangioma. Okay, then your schistosomiasis you get. Even echinococcus, you get echinococcus. This is the second heading. The third heading is splenic infiltration of the spleen. Infiltration of the spleen could be intracellular or extracellular. Like intracellular, extracellular splenic infiltration is because of the amyloidosis. Storage diseases like Gaucher's disease, Niemann-Pick, Hurler's disease, mucopolysaccharidosis, lipid abnormalities. Okay. So, intracellular, extracellular deposition, amyloidosis, Gaucher's disease, Niemann-Pick's, Fabry's disease, Tangiers disease, then lipoprotein disorders, lipid abnormalities, all can produce intracellular, extracellular deposition. Then you have a benign and malignant causes for the splenomegaly. You have the malignancy like leukemia, lymphoma, myeloproliferative disorders like polycythemia vera, CML. Leukemia could be lymphatic, acute, chronic, myeloid, monocytic, and leukemias can involve splenomegaly. Then some of the benign like hemangioma, hematoma, fibroma, eosinophilic granuloma, histiocytosis X. Okay. So, the hematoma, hemangioma, lymphangioma, splenic cyst, fibroma, histiocytosis X, eosinophilic granuloma, angiosarcoma. So, all these things can produce a benign etiology for a splenomegaly. So, first is splenic function is increased, second is altered blood flow, the third is infiltration. Okay. The last is unknown etiology. Unknown etiology, you have a idiopathic splenomegaly, berylliosis, and iron deficiency anemia in the unknown etiology. So, these are all the causes of splenomegaly which Harrison has given. You can go back and make a table. Okay. So, So you should consider the differential diagnosis of all these things, right? So especially in this entity, so splenomegaly may be so many causes, but for a massive splenomegaly, there are only few causes. So what are the causes of massive splenomegaly? In India, it is malaria. You have to consider hairy cell leukemia, non-Hodgkin's lymphoma, chronic myeloid leukemia, polycythemia vera, then chronic lymphatic leukemia, Gaucher's disease, sarcoidosis, diffuse splenic hemangiomatosis. Then even autoimmune hemolytic anemia can produce a massive splenomegaly. So the laboratory investigation, already I discussed what are the things you do in a case like this. Now a few points about the splenectomy. Splenectomy, the indications of splenectomy are, it could be to treat the symptom, that's one indication, or it could be to treat the disease, for example, a traumatic rupture of the spleen, or to improve the one or two formed elements of the blood. For example, in ITP, you may have to do splenectomy, or in hemolytic anemia, you may have to do splenectomy. Those are the indications for the splenectomy. And in a CML, if you do a splenectomy, not only it reduces the symptom, it also reduces the amount of blood transfusion required in CML. Then in Hodgkin's lymphoma, you do non-Hodgkin's and Hodgkin's lymphoma, you do splenectomy for a diagnosis purpose, for staging of the disease. In Hodgkin's lymphoma, 1/3 of the patients, even if there is no splenomegaly, spleen may be affected. And in 1/3 of the patients with splenomegaly, spleen may not be affected even if there is a splenomegaly. Then, in hairy cell leukemia, prolymphocytic leukemia, and a very rare marginal B cell lymphoma or a mantle cell lymphoma, if you do splenectomy, the primary malignancy will be reduced. This is known as abscopal effect. And why this abscopal effect is, probably spleen may synthesize a hormone which will aggravate these leukemias, the prolymphocytic leukemia, hairy cell leukemia, a rare mantle cell leukemia, or a marginal cell lymphoma, which is also known as mantle cell lymphoma. Abscopal effect. Okay, that you should know. Then approximately 10% of the splenectomy is done to diagnose, 44% as a therapeutic option, 20% in lymphoma, and 26% whenever you do a surgery for the other causes, you will do splenectomy. The only contraindication to splenectomy is a bone marrow failure. The only contraindication is a bone marrow failure. Then one entity which you should know is hypersplenism. Hypersplenism is a physiological overfunction of the spleen where there will be a pancytopenia but a normal bone marrow. And these pancytopenia will respond to splenectomy in hypersplenism. The distinction between aplastic anemia and hypersplenism is, in aplastic anemia, bone marrow will be abnormal, whereas in hypersplenism, bone marrow will be functional. That is about hypersplenism. Now coming to the splenosis. Splenosis is in a traumatic rupture of the spleen. Sometimes the splenic particles may be in the abdomen, obstructing the GI tract, producing a pain, something like endometriosis, that is known as splenosis. Then splenectomy can be done by open approach or a laparoscopy. Nowadays they do laparoscopy, but laparoscopic splenectomy has produced more incidence of Buchiari syndrome. Then what are the effects of splenectomy? An immediate effect and a late effect. Immediate effect of splenectomy is, there can be increase of the neutrophil counts to 25,000. Platelet count can become 10 lakh, but both will become normal in 2 weeks. That's the immediate effect. The late effect, you will get a whole body, a healed body, anisocytosis, poikilocytosis, basophilic stippling, and nucleated erythrocytes. These are the chronic manifestation of splenectomy. Okay, you should know about that. Then in a splenectomy, if you do, suppose if splenectomy is not done, but still if you get a whole body, hinge body in the peripheral smear, then that indicates there is a total destruction of the spleen by the infiltration by the malignancy. Okay, right. Then what are the other complications you get of splenectomy, especially infections? You have with Streptococcus pneumonia, Neisseria meningitis, Haemophilus influenza, and one parasite, babesiosis. So here, the usually, especially in less than 20 years, the infection in Streptococcus pneumonia is more common. At least 7% will develop the infection in a 10-year span after undergoing splenectomy, Streptococcus pneumonia infection. The mortality rate of Streptococcus pneumonia sepsis is 50 to 80%, and there is 25% chance that a person will develop Streptococcus pneumonia infection in his lifetime after undergoing splenectomy. Especially the streptococcal infection is more common in the initial first 3 years of life. In 15% of the patients, there will be a polymicrobial infection with the involvement of the lung, blood, skin. The viral infections are very less with splenectomy. And an oral prophylaxis penicillin is not beneficial. You have to vaccinate before splenectomy. For Streptococcus pneumonia, you have to vaccinate 2 weeks before doing the splenectomy. And after 5 years doing the splenectomy, you have to give a booster dose of the vaccine. You have to give vaccine for Streptococcus pneumonia, Neisseria meningitis, but vaccination against Haemophilus influenza is still questionable mark. The parasite which produces infection after splenectomy is babesiosis, so that to avoid going to a place where babesia is endemic. Then few points about hypersplenism and asplenia. Hypersplenism is, suppose if there is an irradiation in a malignancy or autoimmune disease to the spleen, the function of the spleen will be reduced. That is known as hypersplenism. Whereas asplenia is congenital absence of the spleen itself. That is asplenia. Then one point is autosplenectomy. Autosplenectomy is in sickle cell anemia, usually around the age of 5 years, because of repeated microinfarction, the spleen will undergo autosplenectomy, spleen size will be reduced. Actually, in a sickle cell anemia, after 5 years, spleen is palpable, or if it is present, then you have to think the associated hemoglobinopathy like hemoglobin C or thalassemia. Okay, that is autosplenectomy. So this is about splenomegaly and splenectomy. Now, I just want to tell some of the causes of hepatomegaly, combination hepatosplenomegaly and hepatosplenomegaly with lymphadenopathy. Okay, this few examiners will ask the questions: cause of hepatomegaly, hepatosplenomegaly, hepatosplenomegaly with lymphadenopathy. Questions will be asked in the exam. You should know the causes. So coming to the cause of hepatomegaly, infections is the first heading. Infections along the biliary tract is cholangitis. Infection along the portal vein is amoebiasis and schistosomiasis. Infection along the hepatic artery, bacterial infections like tuberculosis, Weil's disease, typhoid, brucellosis along the hepatic artery, bacteria. The fungal infection, actinomycosis, histoplasmosis. The viral infections, hepatitis, cytomegalovirus, Epstein-Barr virus, the viral infections. So infections along the portal vein, along the biliary radical, along the hepatic artery. After infection, congestive cause of hepatomegaly, congestive heart failure, dilated cardiomyopathy. The congestive causes, congestive heart failure, Buchiari syndrome, congestive pericarditis, cardiomyopathy, congestive causes of hepatomegaly. Then you have infiltrative, leukemia, lymphoma, multiple myeloma can go and infiltrate the liver, producing hepatomegaly. Then you have malignancies, hepatoma, secondaries, cholangiocarcinoma can have hepatomegaly. Then you have storage diseases, Niemann-Pick disease, Gaucher's, Hurler's can produce hepatomegaly. Then you have the toxins, alcohol, drugs, arsenic, and then you have phosphorus which can produce hepatomegaly. So under these headings, infections, congestive, infiltrative, storage, neoplastic, toxins. Next, what are the causes of painful hepatomegaly, which I already told, okay, the heart failure, infectious hepatitis, pyogenic liver abscess, amoebic liver abscess, actinomycosis, hepatoma rarely, secondaries, Buchier syndrome can produce a tender hepatomegaly. Then the causes of hepatosplenomegaly, infections, again malaria can produce hepatosplenomegaly, cytomegalovirus, Epstein-Barr virus, tuberculosis, actinomycosis, histoplasmosis. These are all the infective causes of hepatosplenomegaly and bacterial endocarditis. Then you have hematological causes of hepatosplenomegaly like anemia, hemolytic anemia especially, lymphomas, leukemias, lymphoma, myeloproliferative disorders, polycythemia, vera, CML. So hematological condition, hepatosplenomegaly. Then you have congestive causes like congestive cardiac failure, portal hypertension, cardiomyopathy, constrictive pericarditis can produce a hepatosplenomegaly. Okay, congestive causes. Then you have storage diseases which can produce hepatosplenomegaly, Gaucher's disease, Niemann-Pick's, Fabry's, Hurler's, glycogen storage diseases can produce hepatosplenomegaly. Hepatosplenomegaly with lymphadenopathy. The cause of hepatosplenomegaly with lymphadenopathy is HIV, tuberculosis, lymphomas, lymphatic leukemias, sarcoidosis, disseminated histoplasmosis, disseminated tuberculosis can produce hepatosplenomegaly with lymphadenopathy. Okay, so lymphoma, lymphocytic leukemia, infectious mononucleosis, even cytomegalovirus, disseminated tuberculosis, sarcoidosis, HIV, then disseminated histoplasmosis can produce hepatosplenomegaly with lymphadenopathy. So these are some of the questions. I discussed splenomegaly and splenectomy from the Harrison. You can go back and read the Harrison. And about lymphadenopathy detail, I would discuss in examination of lymph node part. You can go through that, the causes of lymphadenopathy and approach to how to examine the lymph node examination. So this is today we will discuss hepatosplenomegaly examination and how to palpate, methods, how to percuss, methods of percussion of spleen, cause of splenomegaly, what are the relevant investigation, and a few points about tropical splenomegaly. So this case is for both undergraduate and postgraduate students. So you can go back and read, students. Thank you.